gentlemen, good morning and welcome to second part of GI scintigraphy lecture. Today we're going to talk about gastric emptying, GI bleeding, and hepatic and splenic imaging. So gastric emptying solid meals, this is what we used to do in the good old days. We used to feed the patient the meal and then dynamically image for a couple of hours, generating these curves and attempt to interpret it. I never quite understood what those curves meant. Unfortunately, I never had to, because eventually we got some normal guidelines and much simpler modern protocol. So Society of Nuclear Medicine and the GI societies have achieved consensus to develop a standard methodology. Unfortunately, again, the normal values were built on a relatively small 123 subject study, but nonetheless, was a significant improvement compared to the normal. Compared to what was previously done. Okay, so quick question. So the exam results can be affected by all except for 1, part of menstrual cycle, 2, high blood sugar, 3, methyl-chlorpromide, 4, Vicodin, 6, smoking, and 7, ondansetron. Very, very simple question. And the answer is 7. Ondansetron is the agent of choice if the patient has nausea and can't eat the meal. Okay. Patient preparation is important. The patient should be fasting for 4 hours prior to beginning of the study. If the stomach is full of food, obviously, the test is not going to work. For patients who are diabetic, blood sugar should be less than 200, so the patients should check the sugar, or the insulin should be adjusted to achieve that target. But in our population, this is something that I don't even go into checking based on my experience with PET patients. The patients live where they live, so we should see what the physiologic emptying really is. But theoretically, the blood sugar should be less than 200. Premenopausal women should be studied on days 1 through 10 of the menstrual cycle, but again, this is an impossible scheduling dilemma, so we don't bother. Prokinetic agents and other medications that can affect gastric emptying should be stopped for 2 days, unless we're actually trying to evaluate the effect of those medications on the patient's gastric emptying. Okay, so this is the recommended meal, and this is how it looks like. So it should include 4 ounces of liquid egg whites, 2 slices of toasted white bread, 30 grams of jam or jelly, and 120 milliliters of water. Salt and pepper are optional, depending on what the patient is trying, if the patient wants to add them. So meal preparation is extremely important. So the sulfur colloid should be mixed with liquid egg whites before cooking, and then the meal is generally cooked in a microwave because it generates the least amount of contamination. The whole purpose of cooking the eggs with technetium is that to bind the technetium sulfur colloid to the egg protein, so we can track the progress of the egg protein. So the easiest source of error is just to cook the eggs and then add the sulfur colloid. That's not going to work correctly. So eggs must be cooked with sulfur colloid. The patient is encouraged to eat the meal relatively quickly, preferably within 10 minutes, and then we obtain anterior and posterior images of the stomach and abdomen at 0 minutes, 1 hour, 2 hours, 3 hours, and 4 hours. It's the 4 hours images that are most important, and if there is more than 10% of the meal retained in the stomach at 4 hours, that's considered abnormal. The reason we do images early is frequently the patients will achieve 90% emptying at 2 hours and 3 hours, so we don't need to keep them for the entirety of 4 hours, although in a busy department it would be reasonable to just image them at 4 hours. These are the normal values for gastric emptying. Again, the only thing that truly matters is 10% at 4 hours. Okay, so interpretation of gastric emptying studies is extremely challenging. This is why I am always happy to read them all, since it is so difficult. And in this example, I'm sure all of you have reached the correct conclusion that this is abnormal with gastric emptying of 72.6% at 4 hours. It should be 90% or greater. Okay, another example, is this normal or abnormal? And I'm sure, again, all of you have correctly answered that this is abnormal with emptying of 69% at 4 hours. This is, again, below the 90% threshold. of emptying or 10% of retention. Okay, how about this example? And again, I'm sure everybody very quickly has answered correctly that emptying of 14.8% or 15% is abnormal at 4 hours. This is an effect of therapy. The scan above is pre-therapy, and we see 4% emptying at 4 hours. And after therapy with medications, we see by 2 hours the patient is emptying at 92%. So again, this is why we image at hourly intervals, because we can frequently terminate the scan quicker. Okay. Sources of error, again, the largest source of error is non-standard meal or not making the meal correctly. Otherwise, if the patient doesn't consume the entire meal as well, this can result in somewhat abnormal and suboptimal test. Okay, liquid gastric emptying, that used to be popular before the modern guidelines came out, but again, it probably is not as reproducible as a solid meal and generally should not be performed. Okay, let's switch gears and talk about GI bleeding scans, and this is what we used to these days. We perform angiography where we can easily see gastric bleeding. We see clot in a non-contrast study, and in a post-contrast study we see active extravasation, and with subsequent angiography confirming active bleeding. These are the Society of American College of Gastroenterology practice guidelines, and you can see is that arteriography and nucleus scans is far down and should be performed after the negative colonoscopy, but the reality is these guidelines tend to be followed more during the day, and at night it's the nuclear medicine test or CT angiography that gets performed. Okay. So, in general, the GI bleeding test can be performed with sulfur colloid itself. However, this is a really poor angiography marker with poor blood pools, so this is discouraged. So in general, these days we only perform technetium-99m labeled red blood cells. A typical dose is about 20 to 30 millicuries, and in theory, this can detect pretty slow bleeds in clinical studies suggesting as slow as 1/10 of a milliliter per minute. There are 3 ways to label in vitro, and this is preferred in modern clinical practice because of its 95% efficiency. There's a mixed in vitro in vivo that has 90% labeling efficiency, and finally there is an in vivo method where labeling is performed in the patient itself, and this is not currently recommended due to its suboptimal labeling efficiency. So these days we only label in vitro, meaning we take the blood out, we label it, and then we re-inject it. The study protocol, in general, we perform a flow study, so the patient is injected while on the table, and we perform a pseudoangiography, although I never found this to be helpful. Subsequently, we generally perform 60 seconds per frame for 60 minutes. We will frequently perform lateral views or delayed views. Lateral views are especially helpful in the pelvis because of bladder activity and genital activity when we're trying to differentiate it from rectal or sigmoid bleeding. Interpretation could be a challenge. In general, we recommend looking at the cine images. That's much more accurate than just the screenshots, although I'm going to show you screenshots because they're easier to capture. Colonic bleeding tends to follow colon anatomy. Small bowel bleeding tends to be much jumpier all over the place. And again, this is much easier to see on cine dynamic images. Okay, some simple examples. Where is the bleeding? And I'm sure all of you have really quickly identified this subtle bleeding in the right colon that becomes brighter as we look at the images. Okay, how about this example? Where is the bleeding? And I'm sure all of you quickly identified bleeding in the left colon. Again, we see this dot. In this on the static images, the dot does not move, so we need to look at the cine images to confirm that the dot is going to be moving along the course of the left colon. Okay, how about this example? Do you see the bleeding, and where is the bleeding? Okay. I'm sure all of you identified these faint activity in the left upper quadrant, And we can see that it doesn't seem to follow the course of the colon when we look at all of the images from 25 to the 36. However, again, on the cine images, it would have been much easier to see the jumping activity that is very typical for small bowel. Okay, how about this case? Where is the bleeding? And I'm sure, again, all of you had no trouble identifying the bleeding in the left colon. What I also would like to point is the activity in the bowel as well as the genitals, which is actually brighter than the bleeding itself and should be identified by a characteristic appearance in the images. So don't confuse it. Okay, how about this case? Now, this is a bit of an eye test, and I'll be honest, we actually failed the eye test and failed to identify the source of the bleeding on this nuclear medicine scan. The bleeding was subsequently picked up on this CT angiography, where I'm sure all of you by now have quickly identified descending colon as the source of the bleeding. Again, I'll go back to the nuclear medicine test, and as we go back, prospectively we have failed to identify it. Now, retrospectively, we see this really faint activity in the left abdomen, which was the bleeding, although, to be honest, again, it was much easier to see on this CTA, and again, we see angiography confirming the source of the bleeding. In terms of research, there's really no head-to-head comparison that was ever performed. There is a single institution study that looked at 45 CTAs and 19 nuclear medicine bleeding tests that were performed during the study interval. So again, there is no rhyme or reason for which one was performed. They were not performed in the same patients. And what they said is that both found etiology of bleeding in the same proportion of patients, approximately 45%. However, CTA was much more accurate at localizing the bleeding. In theory, it is believed that CTA is less sensitive. I'm not sure that is true, as evidenced by the last example, and particularly may not be true in the modern era of dual energy CT, where we can find really, really subtle bleeding. Okay. Sources of error in general, most errors that I see occur due to poor labeling that is performed at night. So we'll see a lot of gastric mucosa from the free tech, as well as failure to look at the study on the dynamic cine images. Okay, so what is going on in this case? And I'm sure all of you have accurately recognized that this is a free technetium in the stomach, as also evidenced by the free tech uptake in the thyroid gland. And this can be quite confusing. Again, for reasons not surprising, more often occurs at night when the technologist is in the hurry to label and re-inject. Okay, Meckel's. Meckel's actually relies on gastric mucosal uptake of free tech, so that's what we do. We inject free tech. Meckel's scan should never be performed during active bleeding. If the patient is actively bleeding, we should use labeled red blood cells. So Meckel's scan should be done when the patient is actually not bleeding, and it has a pretty good accuracy of 90% of identifying Meckel's diverticula. There's published data on using premedications such as H2 blockers and pentagastrian and glucagon. However, the guidelines do not require use of any of them, so when we do these scans, we don't use it, just to make things simpler. So in general, the protocol in adults is about 8 to 12 millicuries of technetium-99m per technetate. In kids, as always, this is weight-based. In the protocol, similar to everything else, is inject dynamically to obtain a flow phase with patient under the camera, and then do typically 30 to 60 minutes of 1 minute per frame imaging. Interpretation is we should see focal diverticular uptake, and the activity generally should not move. And this is an example of Meckel's scan, and I'm sure all of you have quickly identified focus of uptake in the right lower quadrant, which confirms ectopic gastric mucosa in a Meckel's diverticulum. Okay, sources of error. Usually it's due to lack of significant gastric mucosa or recent gastrointestinal bleeding, which can suppress the uptake of free TEC. But in general, I find this to be quite helpful. Okay. Finally, let's talk about hepatic and splenic imaging, and this includes imaging with sulfur colloid for reticular endothelial system, imaging with technetium red blood cells to image the blood pool, hepatic perfusion with technetium MAA, as well as splenic imaging with heat-damaged red blood cells. And all of these have niche uses. These are the radiopharmaceuticals, typical doses, as well as organs receiving the greatest amount of radiation. Notable for the technetium-labeled red blood cells, the organ receiving the greatest radiation is the heart, due to excellent blood pool properties of TEC and exposure of the heart to blood. Okay. Let's talk about liver spleen imaging. This relies on technetium 99M sulfur colloid, which is taken up by reticular endothelial system. So we expect to see liver, spleen, and blood marrow. In general, liver should be the brightest. If spleen is the brightest, this is so-called colloid shift, which is seen in hepatic dysfunction. But again, these days no one uses it for that purpose. Nonetheless, in theory, it could be tested. This is a normal physiologic scan where we see liver as the brightest organ, spleen as well as faint uptake in the marrow. This is abnormal, and I'm sure all of you really quickly recognize that spleen is brighter than the liver, so this is colloid shift indicative of liver dysfunction. This is a priceless case. I suspect it's pretty difficult to find one of these days in real clinical practice. Okay. This is more practical. Take a look at the images and what is going on. And I'm sure everybody has quickly identified multiple foci of tracer uptake throughout the abdomen. So this is splenosis after trauma. Actually, if you look at the spleen and the posterior images, you can see a wedge-shaped defect. That was probably remote splenic laceration that resulted in seeding of splenic tissues throughout the abdomen, which is confirmed by this test. Okay, dedicated splenic imaging is, however, best performed with heat-damaged red blood cells, because that's the whole purpose of the spleen is to remove bad red blood cells from the blood pool. And so this is superior to conventional sulfur colloid imaging. Okay, this is an example where abdominal CT shows multiple hypervascular nodules in the abdomen, specifically in the right lower quadrant. And then heat-damaged RBC test is performed using SPECT CT imaging, and we see that those hypervascular nodules show remarkably high uptake, as well as absence of a normal spleen, confirming post-traumatic splenosis as the underlying etiology. And on the previous case of sulfur colloid, the uptake was relatively faint, with most of the tracer in the liver, and with a heat-damaged RBC, it's the opposite. The splenic tissue in ectopic location is the brightest thing on the scan. Hepatic blood pool imaging, I've never seen this in clinical use, but only with great difficulty I found this case report that was published in the mid-90s. So we see a hyperechoic nodule in the liver in ultrasound, and blood pool imaging demonstrating accumulation of red blood cells in this hemangioma. This is a hepatic perfusion scan that's performed prior to radioembolization of the liver. In example A, all of the technetium MAA is aggregated in the liver with no lung activity, and in example B, we see substantive lung activity. So if patient receives a full dose, there's a high risk of radiation pneumonitis. So this is always performed prior to radioembolization. To calculate the shunt fraction, and in general we're looking for less than 10% shunting, and if the fraction is higher, this can still be performed, but the dose needs to be adjusted. Okay, so in summary, gastric emptying standard solid meal, and the threshold is if there is more than 10% retention at 4 hours, the test is abnormal. Remember that the eggs must be cooked with sulfur colloid to achieve appropriate binding. Bleeding scans with technetium-99 labeled red blood cells can detect bleeding rates of up to 1/10 of a milliliter per minute, which may be too sensitive in clinical use. And remember that these days we only do in vitro labeling, so in a lab, and that achieves the optimal greater than 98% efficiency. And in general, we should be looking at these on cine images. Meckel scan are pretty accurate, but they should never be performed during active bleeding because this decreases the sensitivity of the scan. Liver spleen imaging can be performed with sulfur colloid that is taken up by the reticular endothelial systems. However, when we look for ectopic splenic tissue, heat damage RBC is superior. And liver perfusion with technetium labeled MAA should always be performed prior to hepatic radioembolization to exclude lung shunting. All right, thank you very much.